Good morning, good afternoon, everyone. Welcome to the launch of the Perinatal Mental Health Community of Practice. We're going to give everyone a few minutes to be able to join. So there may be a bit of silence from us for the next minute or two while people have an opportunity to log on to the webinar. So bear with us as we get started. Thank you. All right, thank you. Good morning, good afternoon to everyone around the world. We are thrilled that you have chosen to spend your time with us this day to help us launch the Perinatal Mental Health Community of Practice. And I'm very pleased to say that for this webinar, we have over 800 people registered. So I think that that is a great indicator of the interest that this topic is sparking around the globe. So next slide, please. So my name is Suzanne Stahls, and I'm the director for the maternal newborn team here at Momentum Country and Global Leadership. So I will first walk you through the agenda of today's launch, and then we'll begin to dive into the substance of what we want to discuss about this community of practice. So the agenda is clearly welcome and opening remarks. The opening remarks will be given by Robin Churchill, who's the maternal health team lead at USAID in Washington, DC. And then we'll be discussing the evolution and the ideas and the context behind the development of this LMIC-driven community of practice. Then we'll introduce the community of practice itself, its leadership, and some of the beginning structure and framework for this community of practice. Then we really will have a number of, quite a few minutes to be able to entertain questions, feedback from our participants so that we can discuss those with the presenters of this webinar. And then lastly, we'll discuss how do you engage with this community of practice and next steps. So now what I'd like to do is turn it over to a recorded remark by Robin Churchill, and that will open our webinar. Thanks so much.
And welcome everyone to the launch of the Perinatal Mental Health Community of Practice. I'm Robin Churchill, the maternal health team lead at USAID Washington. I'm so excited to be here with you today in the broad sense, and I'm very sorry to miss the event in person, but what an exciting meeting and movement to be part of. I want to emphasize USAID's commitment to this work to address perinatal mental health across our portfolio. As with many of you, the more we have learned, the more we recognize the critical need and the power of coming together to elevate the focus on perinatal mental health at local, national, and global levels. This is the moment. I was once asked if I had any experience in mental health care, and I started to say no, but as I thought about it, I realized that as a midwife, I worked closely for decades with my mental health colleagues to bring resources to address mental health needs of my clients. And then I thought more about some of my family members who have struggled with depression, with whom I've had to attend therapy sessions, help them manage medication, and have had to walk beside them in their struggle. And I think that's nearly all of us. In one way or another, we have all some kind of experience with mental health. And that's why we're here. So we know we have to listen to women, and women are hurting. Maternal depression is the second largest cause of disease burden among women worldwide. Suicide during pregnancy and the postpartum period is a leading contributor to maternal mortality. How big is this issue? Systematic reviews have found pooled prevalence rates ranging from 5 to 33% during pregnancy and up to 59% in the postpartum period. One systematic review of antenatal depression found prevalence rates in Ethiopia as high as 78%, and that's just too much to ignore. As we know, these high rates of depression have physical consequences as well. So today we are coming together to join forces to help the world's women and families whose mental health needs are not being met. Today is about starting something collectively to address PMH around the world. This won't be easy or quick. We are all here for the long haul, for the hard work, for the long labor ahead. But look around this virtual room. This is what a movement looks like. I'm honored to be here as one of you, to learn from you, to work alongside you, and to do something for the world's women and children who will survive and thrive when both their physical and mental health needs can be met. I look forward to the launch of this community of practice and to the impact I know you will have. Thank you to the steering committee and to each of you here today. I know you share my excitement for this event and for the work moving forward. Shannon, over to you to get us started.
Next slide, please. So thanks to Robin, and really thanks so much to USAID for their support and their interest and willingness in driving this initiative forward, recognizing at the same time that today, many of the speakers that you will hear and the members of our steering committee have been people that have been working now for years and decades in many instances to advance this topic of maternal mental health. So we are incredibly pleased to be able to collaborate with colleagues around the world. And just a reminder, I want to make sure that our participants understand that you can begin to drop questions that you might have into the Q&A function. So, and then as we move into the question and answer session, we'll be pulling from the questions that are in that particular chat box. So I have the honor and privilege now to introduce you to our community of practice co-chairs. And the first person is Ife Yusuf, who is with the Innovations for Poverty Action in Nigeria. And then our second co-chair is Prabha Chandra, who is with the National Institute of Mental Health and Neurosciences in Bangalore, India. So we're extremely grateful that they are willing to bring their talents, time, and commitment to this, and that they are here with us today. So next slide, please. And now what we'd like to do is introduce the technical working groups of the community of practice. And one thing I'd like to mention before we start talking about the technical working groups and a little bit more about the framework and structure of the community of practice is that this is really a work in progress. And we have initiated this community of practice, but it's by no means fully defined, or nor do we know every bit of the strategic directions that will be taken. So this is really an opportunity for participants to engage with us and really begin to provide input in the direction and the shape of what this community of practice looks like. So with that said, I'd like to introduce you to the co-chairs of the Technical Working Group for Resource and Learning. That is Becca Levine from Palladium in the United States, Linus Mavuhu, who is the founder and director of SPANS in Zimbabwe. Then the next technical working group is for Evidence and Impact, and that's co-led by Genesis Chorway from the Kamuzu University of Health Sciences in Malawi, and Jane Fisher from Monash University in Australia. The technical working group then for advocacy and knowledge is Tafat Swamiki with SALT Africa and Zimbabwe, and Fiona Koyet. I hope I'm saying everyone's names correctly. So who's with World Vision in Kenya. And lastly, but not least, certainly the Adolescent Technical Working Group that's co-chaired by Joanna Lay from UNICEF at Global Headquarters, and Manasi Kumar, who's at the Department of Psychiatry at the University of Nairobi in Kenya. So now what I'd like to do is hand it over to my colleague, Shannon McNabb, who will help us understand where we've come from in the past 2 to 3 years that we've had the fortune to engage with colleagues around the world and begin to shape some of this agenda.
Great, thanks, Suzanne, and thank you, everyone. As Suzanne mentioned, I'm going to present for a few minutes before we get into the exciting purpose of the meeting. There's just a little bit of background for how we got to this place that we are today. Thanks. So about 2.5 years ago in 2021, you can see that's PY2 is 2021, we started with the landscape analysis, and I'll talk a little bit about that has really seen a progression of activities from technical consultations, various publications, the creation of a theory of change, and then ultimately has culminated in this community of practice. So just to set the scene for you all for when IFE presents where we are now, that we can help explain a little bit of how we got here. Next slide, please. So in 2021, we published the Silent Burden, a landscape analysis, and this was really looking at common perinatal mental disorders in low and middle income countries. And it was an attempt to scope and look at across the board, what is the prevalence? What are the risk factors of common perinatal mental disorders? What are the implementation strategies that are currently being implemented? And then also, what are some of the research questions and issues that we don't yet have evidence for? So we conducted this landscape analysis and included over 400 articles and 60 key informant interviews to really get a wide swath of what is happening in this field and figuring out where the field wants to go. And as Suzanne said earlier, we also recognize there are so many people working in pieces of this, the perinatal mental health space, that we wanted to continue to bring together. Next slide, please. Something that came across very clearly was the importance of perinatal mental health on maternal health and outcomes. So, and when we're talking about CPMDs, we're talking depression, anxiety, and somatic disorders. And we're finding in our landscape analysis, and which has been subsequent to multiple articles that have come out for many of you on this call today, you know, when women are experiencing CPMDs, they're less likely to attend A&C, P&C. They're more likely to experience obstetric complications and have preterm birth. So this is an extremely important area, and I think it speaks a little bit to what Robin was saying as well. As more and more attention is coming to the the connection between perinatal mental health and mental health outcomes, I think it's becoming clear that we need to continue to work together. Next slide, please. But then also the implications on the child and the newborn health are significant. So women who experience CPMDs have their babies experience stunting and underweight, wasting, and lower cognitive development. So this need to look at the mother-baby dyad and look at the mother's maternal health as well to support the child's outcomes and development were very clear. Next slide, please. Our landscape analysis then left a lot of questions and a lot of interest in how do we move this forward. And so we held a technical consultation in September of 2021 over 2.5 days with the WHO and UNFPA to really take some of the conversations and the issues that haven't been addressed or that really need further unpacking and bring together a diverse set of participants. Next slide, please. So what we tried to do here, we had over 700 participants, and what we wanted to do was bring different fields that don't necessarily always connect, right? So the maternal health field, nutrition, gender, humanitarian, the faith-based community, to come together and discuss how we can work and some of the issues that they're recognizing. We're able to have dynamic conversations about where the needs are, where the gaps are, and also what do we know that is working right now, and sharing some of that data and evidence. Something that came out very clearly was a call for two things during this technical consultation. The first one was, can we galvanize behind a common understanding or a global theory of change? So can we sort of bring forces together to think about a global theory of change that could be used for low and middle income countries in particular to sort of base our work off of and align behind? And the second was the creation of some type of community of practice. Next slide, please. So for the first step was a global theory of change. We chose to work with a human-centered design firm and several of our steering committee members from various countries around the world to start to say, what would be most useful? And we ultimately created a theory of change based on a socio-ecological model so that if a user wants to work at, say, a community level, you can go and look at that community level and understand what are some of the interventions, what are some of the questions that need to be answered. And so we co-created this theory of change. And what came with it was, next slide, please, an opportunity to also elevate some of the research questions that need to be answered and that continually come up in conversations. And what we found as we did these prioritization activities was that the research questions that people continued to say were really important and fundamental to us addressing perinatal mental health fell really nicely along an implementation pathway, right? So questions around what does mental health mean to women? What do communities and women actually want? What are outcomes of interest? To how do you prepare a health system to integrate perinatal mental health into existing platforms? And then one obviously very extreme challenge I think we're all addressing right now is this question of how do we scale with quality? And so we put forward and co-created this implementation pathway of these research questions along that pathway so that some of us can coalesce as we move forward to start to inform each other in some of the work that we're doing. Next step, please. And then following this, and again, this came out of the technical consultation very clearly, was there are several people, hundreds if not thousands, working and thinking about this issue, whether they're academics or Ministry of Health representatives, implementers, women, providers, trying to understand what is it they can do to promote good maternal mental health. And what is a way or a mechanism, a place that we can come together and share information? And so this community of practice really has come out of our landscape analysis, the technical consultation, the growing interest in coming together as a community around the theory of change, and then bringing us here to today. So before we launched this, there was several months of background work here. So next slide, please. We sent out a survey to get a sense of who's interested in joining, what type of role are they in, what would they find most useful, and then what are the mechanisms and the types of activities they would want a community of practice to provide. And I want to be very clear that we recognize and respect that there are alliances and partnerships and networks that exist right now that are addressing this. And so this is not, as Suzanne mentioned, this is not trying to separate ourselves. We want to continue to integrate and work with those who are currently working in this space as well, but also fill a much needed gap. Next slide, please. So lastly, here's what came out of the survey. So we asked, again, as I said, we asked what people wanted, and in the top left of the screen is they wanted a space to help learn and talk through creating, reviewing, and curating tools. Advocacy, how do we advocate? What are tools? What information do we need for advocacy? And training and strengthening of local capacity. And it's particularly some of our colleagues and steering committee members working for smaller NGOs, how can we share some of the capacity back and forth for those of us who are working on it? In terms of the engagement mechanisms, webinars, meetings, can we come together? Can we share information? And then also discussion boards and chat groups were the top 3 engagement mechanisms. And then in terms of the services, very practically, what can we do with a community of practice? The first is knowledge sharing events. So, webinars, and can we bring people together who are working in this field? The second is training or deep dives. This is really interesting too. People want to be able to have a space to talk about some of the stickier issues around perinatal mental health. And third is knowledge products. So can we create case studies together? Can we create advocacy tools? Can we do something that can be used in multiple contexts in multiple countries for the purpose of pushing forward perinatal mental health? So with this last 2.5 years, we are very grateful for your time and the energy that's gone into this. I'm going to turn it over to my colleague, Iffy, right now to tell you a little bit about the community of practice. Thank you, Iffy.
Thank you very much, Shannon. It's great to hear from you, and I'm highly delighted that we are here today to launch our community of practice. So I'm going to take you through the journey around how we started the community of practice. So using a human-centered design, the steering committee came together to have various workshops, and we had 3 workshops. From the very first workshop, we were able to sort of set aside our priorities for the community of practice, identifying potential partners will be very crucial to our goals. And from there on, we had the second workshop where we defined the roles and responsibilities of our community of practice members. How are we going to work? What are the key areas that we should focus on? And following that workshop, we had a third workshop, which essentially defined all of the roles. And from there on, we also started nominations for the technical working groups, for the co-chairs and the leads. Next slide, please. So here is our structure for the community of practice to guide how we work and to ensure that from the survey, we're able to address the various needs that were identified. We'll have a steering committee, and within the steering committee, we'll have the perinatal mental health co-chairs, and we also have the secretariat members. We have the active members and technical working groups working under the PMH co-chairs, and we also have the community managers and knowledge management advisors collaborating with the secretariat members within the community of practice structure. Next slide, please. So here for the community of practice, we essentially identified what would be our drive, what is going to be the goal, the purpose of the community of practice. And we felt it was going to be a great opportunity to create a collaborative space for people to share lessons learned, discuss best practices, and also bring on board their technical knowledge towards the field of perinatal mental health, bringing on board persons from various backgrounds within the public health space and healthcare workers and professionals, including those with lived experience from various continents across the globe, be it LMIC or high-income countries. And we also looked at having goals that make provision for us to connect with other persons to promote, prevent, and also offer care and treatment avenues to disseminate program experience and share latest evidence, which are not limited to peer-reviewed journals, but also implementation guidance to offer evidence-informed strategies that will be helpful for implementers within the perinatal mental health space, while also focusing on creating a collaborative and inclusive environment that promotes collaboration and communication to improve networking across a range of audience and groups to ensure that it's not excluding vulnerable groups within the space. Next slide, please. So for us, we identified key goals that are crucial to our community of practice. And I'm going to take you through 4 of our key goals. And one is to essentially open up space to allow for dynamic dialogues. So within the maternal health space, we're looking at opening up conversations that speaks to strategies that are being used to integrate PMH approach into sexual and reproductive health programs, into child and adolescent health services, including nutrition services within the health space, within service delivery, interventions, and also community-led interventions, and also to serve as a knowledge sharing platform to strengthen PMH interventions and programs by sharing tools, resources, evidence, ideas, and experiences that will be beneficial for persons within LMIC settings, and also to provide a platform for cross-country learning where we can have conversations towards advocating for integration of PMH interventions and solutions, and also having policy dialogues to inform policies, and also most importantly, making an investment case for PMH to be prioritized within these settings. We're also looking at having a support mechanism where we're supporting dialogues, information sharing at the community and service delivery level so that we're able to drive meaningful collaborations and conversations between stakeholders within communities. Next slide, please. So looking at that, we have, following the survey and identified needs, we defined key areas that the technical working groups will be focused on, and there are 5 of them. The first is on evidence and impact, and we know that we all need evidence to be able to influence policy and to improve implementation of national programs so that they are effective for the people that need them across the sociopolitical group, using the individual, community, the states, the government, to be able to influence across the scope, and also resource and learning. It's very important to have a knowledge base where people can access resources that are open source and be able to share evidence and products that will be beneficial for the perinatal mental health interventions. Also, we looked at, we have the engagement and coordination technical working group focused on liaising with government, funders, multilaterals, and high income to improve impact of perinatal mental health interventions. And also we have advocacy and knowledge translation that focuses on using data, making evidence available to be able to support expansion of perinatal mental health advocacy efforts to mobilize communities and government. And these knowledge and advocacy and knowledge translations are available and will be discussed in a later session by my colleague here. And most importantly, we've also identified the need of adolescents within the space as one of the groups that are highly ignored, and looking at not needing perinatal mental health support. So we are also prioritizing that, and we have a technical working group team that is going to help to ensure that the needs of this group are also integrated in whatever products that we're also discovering and articulating and putting together. And just to mention that we're also open to having persons who are interested in leading or driving the engagement and coordination technical working group. So we're open to having persons who can volunteer their time to support the technical working group for education and coordination. Next slide, please. So within the community of practice, we have prioritized our engagement approach to focus on integration, engagement, and advocacy. Now, for the integration side of things, we're looking at working with best practices by WHO to ensure that we are developing packages that focuses on integration, having like an integrative model of approach that implementers can use, and also having a video that explains the theory of change approach that will be beneficial for government stakeholders and implementers, and having mentorship opportunities for implementers and researchers, essentially creating that integration so that across board we have one voice, and we're also looking at how we're working to improve across the spectrum of the work that we're doing to ensure that the persons in need of perinatal mental health services are able to receive them as when needed. And also looking at engagement, we're looking at having convenings to be able to share lessons learned, to be able to share experiences and evidence, and also engaging with persons who have experienced one form of common PMDs. And like a saying goes, you can't decide what is for us without us being on the table. So the community of practice has an open door policy for persons who have lived experience to be engaged in these discussions, to be able to drive forward what the needs are for them and how their needs can be addressed. And also looking at having webinars and repositories to be able to ensure that these tools and resources have a database where they are stored and accessible for everyone. And lastly, we're looking at advocacy, very crucial, because for whatever evidence that we generate, for whatever products that we develop, it will be great to essentially have the policymakers be able to hear from us, to be able to be part of the process, even when we're developing policy frameworks, to be able to support interventions, and as well as developing advocacy toolkits for policymakers and for government, and supporting and being involved in policy dialogues and making investment cases for perinatal mental health interventions, and most importantly, leveraging on relationships from high-income countries to be able to share best practices and promote cross-collaboration in the PMH space. And we are not forgetting the vulnerable populations who we believe are beneficial to our interventions and the reason why we are here, to support them through digital solutions, innovative platforms, and encouraging vulnerable groups to be part of our discussions, and also developing tools and products that will be beneficial for this group as well. Next slide, please. So this will essentially be taking us to feedback and discussions. I'll hand it over to Susan. Thank you.
Okay, good morning, good afternoon again to everyone. And please, again, as we noted, we are happy to respond, and in fact, really wanted to open up a fair amount of time for questions and answers so that, as we said, we can both learn from you and learn your particular interests. So as we move forward, we're able to shape this in response to the needs and the kind of advantages that can be gained through a community of practice. So I'd like to just look at our first question. And the first question that we have is, what role does mental health medication have in this work? So what I'd like to do is turn that question over to Dr. Chandra. So Dr. Chandra?
Thank you for that question. And it's so important to remember that any woman who needs medication, whether she's pregnant or in the postpartum period, should not be deprived of that. I think there's a lot of apprehension and fear around the use of medication. So the need for a good stepped care approach, the need for good referral pathways to specialists, and in countries which do not have enough specialists, to ensure that primary care doctors get trained in the rational use of medication and the safe use of medication while treating both the mom and the baby. So I think the community of practice is, it emphasizes that we really need to use medication when it's necessary. And I'm sure we will be able to develop resources which will be available for training primary healthcare staff and both nurses and doctors and midwives on how to use medication safely.
Thanks so much, Dr. Chandra. So now, in looking at, again, in our question and answer chat box, I see a question from Judah Siambe, who is currently managing a community-led maternal child health program using the care groups approach. And do we have any advocacy materials for perinatal mental health that could be adopted to a care group platform? So I do want just one point of clarification, Judith, if you could drop this in the chat. When you are talking about care groups, are you talking specifically about care groups that are for maternal and newborn health? And is it directed towards any time period during pregnancy or postpartum? And that would help us. If I will just throw something in here before I hand it over to Shannon, which is that we were able to incorporate perinatal mental health strategies into a group antenatal care project that we facilitated in Afghanistan. And it unfortunately wasn't able to run for the amount of time that we thought it might. But in any event, it was certainly well received. So I think, again, one of the things to consider is that you want to, just really we want to give careful thought to any number of platforms through which or on which perinatal mental health can be supported. So let me just turn this over quickly to Shannon and ask her to answer some more.
Hi, thanks, Suzanne. And thanks for the question. I think one of the main benefits of this community of practice that we're hoping to achieve is to bring together different tools. So we don't have in particular an advocacy toolkit at this point. And I think our advocacy technical working group will touch on this need as well. But I think this is an opportunity for anyone who is looking at these issues to share the tools that they have. You know, we have the evidence, we have a landscape analysis, we have multiple articles from several of our colleagues in terms of, you know, sort of making the point, making the case. But in terms of a specific advocacy toolkit, we don't have that. But I'd welcome anyone to join or to link in the chat if you are working on this. I know this has been a hot topic of conversation, and in terms of also at what level, right? At policy level, at subnational level, facility level, community level. So I would just like to welcome people to share their resources and make sure that this is a part of the community of practice that we continue to see flourish.
Thanks very much, Shannon. So the next question that we're looking at is a question that's coming in from Nepal. And the statement there is that poverty-related distress, helplessness and hopelessness is really causing a suicide crisis that are being accompanied with written suicide notes. So I think we might be able to go ahead and just talk a little bit about how perinatal mental health, there are certainly instances of self-harm and how that can be addressed within a perinatal mental health platform. So again, Dr. Chandra, if we could ask you to go ahead and respond to that.
Thank you, Susan, for asking, and also Padma for raising this very important issue. Like we know that suicide and self-harm is one of the topmost causes of mortality, perinatal and maternal mortality within the first year of childbirth in most high-income countries. The scene in low and middle-income countries is no better. While it might not be the topmost cause, it is a very important cause and often neglected. So I'm really glad that this was flagged. I think the important thing to remember is that in many countries, it is social determinants which influence, self-harm, particularly in countries in South Asia, where domestic violence is one of the commonest causes of suicide attempts and self-harm in women, particularly in the perinatal period. So I think the important thing here is to identify the risk for self-harm, to ask women about self-harm if it appears sort of evident, and ask even if it is not very evident, because there are things which are quite hidden. Identify depression very early on in pregnancy, identify the risk factors, and try and link women with other support services. So even if perinatal mental health services are not very well developed, in many countries, there are services for domestic violence and other gender-related support, or cash transfers or benefits. Like you highlighted, Padma, poverty is one of the main reasons why women sometimes feel very helpless. So I think we need to remember as perinatal mental health professionals that we can't work in a narrow mental health or a biomedical model, and that we need to connect and liaise with all the organizations working in that area. I think it's an important area, and the community of practice will definitely address this and come up with some guidance about how to identify risk factors, how to intervene early, and how to partner with other organizations to reduce self-harm and suicide. Thank you.
Thanks so much, Dr. Chandra. So now in the chat, we have a question from Mubaraka Bera, who's from Jimma University in Ethiopia, and just appreciating the webinar itself and then this initiative to create the community of practice. So he had a question about, just again, very clear that there are a number of initiatives that are really gaining traction, but also wondering, where are men? And how can we look at this in a way that engages men as well? So I wanted to turn that over to Iffy to see if she could speak to male engagement in this topic.
Absolutely. Thank you very much for that question. The men are fully involved and our community of practice is open. We have 2 men within our technical working group, and we've also announced that we have the engagement technical working group open for persons to join. So maybe we'll prioritize men joining that technical working group. You will agree with me that perinatal mental health it has its social-cultural dynamics to it. And what is more important is at the point in time where a woman needs help, it's always very crucial for her partner to be part of the process. And we can't have an intervention or strategy without the men being involved. So community of practice is open for male involvement, and we are very excited to have men join our community of practice. I hope I've been able to answer your question. Thank you very much. Yeah, I'll pass the mic over to Susan.
Thanks so much, Iffy. And I just so that our participants are just keenly aware that all throughout the landscape analysis, the technical consultation, the topic of male involvement was one that featured really prominently. So I think that this is something that we need to continue deep analysis and discussion of, how men both contribute to perinatal mental health in positive and negative ways, and how we can support them as well. So thanks for that, Iffy. So I am looking now, there's a question from a neonatologist who is working on mental health for women, and women in particular who have lost their infant either through stillbirth or neonatal death. And the question is, are there specific tools that have been developed for that population? So Dr. Chandra, if you could answer that, please.
Thank you for that very important question. I think this is a very vulnerable group, and even neonatologists, obstetricians find this so hard to handle, and moms often feel that they haven't been spoken to enough, they haven't been listened to enough, and couples go through grief and bereavement in different ways. I think the important thing, like you mentioned, is to be able to talk about grief and to be able to support women and their partners and their families. And we are very keen as a community of practice to develop methods, give a script, give words, give a protocol to practitioners on how to handle this, probably develop a course, because we've often found obstetricians and neonatologists struggling with how to manage, because they themselves also deal with a lot of stress, leading to burnout sometimes when they need to handle stillbirths quite often, or when they feel very, very bad about it. So I think the community of practice needs to develop 2 things. One is to be able to help and support practitioners to be able to manage their own grief and loss related to stillbirth and neonatal death, and also to support families. So it's very much on agenda. We have partners who work in this area, and we definitely hope to develop methods which will be available to others.
Thanks, Dr. Chandra. So I think we can all see that there is a theme emerging for the community of practice itself as really a platform for exchanging resources and gaining knowledge of different approaches and interventions that take place around the world in particular contexts. So the next question that we have, and again, I think we can answer this one relatively quickly in the sense that it's from Samrina in Afghanistan. And she's working to integrate perinatal mental health into the healthcare system. And how can she access and what are the resources, specifically the advocacy tools. And again, Samarina, one of the suggestions that we can make is that there is a technical working group on advocacy, and that may be the perfect place for you to plug in and begin to not only understand, but help us shape what is key in terms of creating those advocacy tools. So this is a comment from Yana at Mother Hope Indonesia. And she, again, is making comments on how we can create discussions and collaboration within LMICs. That is going to be, or is the function of the community of practice. So this other question is, mothers are sometimes experiencing extreme mental health crises requiring inpatient hospitalization, but there are very few beds available for these kinds of hospitalizations. And I think this really, in some respects, is also an advocacy question, because how can we interest governments, donors in creating additional infrastructure and resources for specifically that can address and respond to perinatal mental health crises. And Dr. Chandra, if you'd like to answer that.
Thank you. A topic really close to my heart. Most sort of high-income countries have mother-baby services, specialized facilities, but we know that many countries, most countries in the low and middle income zone don't really have these services. People think it's very expensive, it can't be managed, but we in Bangalore have developed a fairly low resource service for women, both an outpatient and inpatient service. We'll be very happy to share our experiences with this community of practice. We've written a book about what you can do to sort of manage this in a way that's culturally acceptable, not very high cost. But I completely agree that this is an advocacy issue, that psychiatric societies around the world should take it up on priority. As part of the World Psychiatric Association position statement on perinatal mental health, we have said that this is a very important thing that we all should be addressing. So I think it's something that should be prioritized, because we know that severe mental illness in the perinatal period is a crisis, is an emergency, and it cannot be ignored. So I completely agree, and we will be sharing some of these resources and models with this community of practice.
Thanks so much. As you can see, we definitely have panelists who just have deep experience and the ability to tap into multiple resources. So again, thank you, Dr. Chandra. So this is another question for Dr. Chandra, just thinking about perinatal mental health and its relationship to both wanted pregnancies and unwanted pregnancies, and particularly in reference to unwanted pregnancies or unwanted pregnancies that result in termination, and or wanted pregnancies that result in a miscarriage, for example. And so very critical need, again, in terms of mental health, and just wondering, what are the resources for that specific population? Thanks.
I think this is such an important area globally, may not be just in the low and middle income countries, even in high income countries, I think, where there are so many layers of complexity related to abortions, both miscarriages as well as those related to unwanted pregnancies, stigma, fear, lack of services, and the sort of dealing with the loss of pregnancy very early on. I think it's another area which hasn't got enough attention, and it's something that we really need to prioritize, because we know that women may have repeated abortions. We know that women who've had an abortion earlier find it very, have high levels of anxiety in a subsequent pregnancy, debriefing, support soon after a miscarriage or an ectopic pregnancy or any other form of abortion or miscarriages. So important to prevent future, depression or anxiety. So it's an absolutely important area. So like we discussed about stillbirths and neonatal deaths, I think this is something which is a priority for the community of practice, and we hope to develop and share tools that are already available, but also develop something which is cost effective and for midwives, nurses, doctors, and indeed families to support women who lose a baby for whatever reason early on in pregnancy.
Thanks so much, Dr. Chandra. We now have another question that pertains to a different area of perinatal mental health. And this person who's asking the question is working in refugee camps in Tanzania. So very clearly issues of maternal mental health, perinatal mental health arise within this context. And however, the question being posed is that there isn't really available a robust system or programming in addressing these issues in this population, and that typically general counseling approaches are used. So the question really is, are there modules that can be used in or within this specific population? And my colleague, Shannon McNabb, is going to take that question.
Thanks, Suzanne. This was an important, component of our landscape analysis, was talking to colleagues working in the humanitarian sectors. We had conducted 2 focus groups with professionals who are working in the humanitarian sector. And this is, perinatal mental health is a real gap right now in terms of the tools and the strategies that exist. IWAG just published probably a month ago a perinatal mental health in humanitarian settings brief, and we can link that in here to really talk about some of the tools that can be used. But I think it's being recognized that the MHPSS in general in humanitarian settings is pretty strong, but really focusing in on the perinatal period for women is an area where there needs to be a lot more research, a lot more understanding and action. So we can drop the brief in, but I think this will be a conversation that will continue in both the development and the humanitarian sector of how to meet the unique needs of women in conflict and fragile settings.
Thanks so much, Shannon. So now what I'd like to do is turn a question to both Iffy and Prabha to talk about working in perinatal mental health in different cultural contexts, and how those how that work can be tailored to the specific cultural context. So really, how is the issue of cultural safety being considered when we begin to think about how, what questions are posed and what solutions and responses are developed in regards to that aspect of responding to perinatal mental health. So we'd love to hear from our colleagues who live this every day.
So maybe I'll go first.
Surely.
I think it's such an important issue because, one needs to focus on stigma. When we talk to women, and do focus groups with them about, the barriers and the facilitators for discussing mental health in the perinatal setting, what we hear from women is, issues related to confidentiality, the fact that while they're in the clinic, their mother-in-law is hovering around, or there's another female relative, just there, or the person who is the midwife is from the community and they don't feel very safe. So I think those are the kind of issues that we need to work with. They also talk about the stigma of mental health. So if a woman is identified as having a mental health problem, they fear that the stigma will actually make things worse for them. But on the other hand, women have also told us that they would like to talk about the mental health issues and distress with their healthcare providers, and to offer safe spaces within the existing systems to be able to express their problem. They've also told us that they would like a more conversational style rather than questionnaires, because that makes them feel safer. So I think these are things that each culture, each setting will have to develop based on what they find. But I think the other thing that women often have told us that they find it very helpful to talk to other women in the antenatal or the postnatal setting who are going through similar problems. So offering opportunities and avenues to do that. Finally, I think male engagement in most South Asian cultures and settings, in public health settings, men rarely come to the antenatal care setting and have never ever met, I mean, a majority of them have never met the healthcare provider. So I think, developing these methods to ensure that the woman feels safe and feels confident of the mental health care which is being provided is extremely important. Involving faith-based services is again very important, and I'm sure if we will talk about it, but the pathways to care very often don't happen directly to a healthcare provider when there's a mental health problem, and often happens to through faith-based services or traditional healers. And I think involving them in this whole system of care is extremely crucial.
Thanks so much, Dr. Chandra. Please, Effie.
Thank you very much. Dr. Chandra, thank you so much. I would like to touch on the engagement with faith-based organizations, traditional birth attendants, women-led groups. These are community structures that are highly recognized by women. And oftentimes, we see women seeking support from religious leaders just to be able to thrive within that period. So the community of practice is going to explore various social dynamics to ensure that we're developing advocacy tools that can be contextualized. And it's great to know that within the technical working group, we have persons from diverse backgrounds, from Kenya, from Nigeria, from Zimbabwe, from Malawi. So within the technical working group, we're going to harness the various social-cultural dynamics and be able to contextualize whatever advocacy packs and tools or products that will be developed so that it will be beneficial for persons across the various regions to be able to contextualize their interventions, to speak to these community structures and be able to lean in on their strength to be able to offer support to these women, and it will be beneficial as well. Thank you very much. I think that will be all from me for now.
Thanks so much, Effie. And we're seeing a number of questions that are coming up in the Q&A box that have to do with education and training of clinicians. And I think that also is a very important question, particularly when it comes to first-line providers who would be the ones that would encounter women first and who might be the providers to whom the client begins describing her experience. So I think one question really has to do with just what resources are available, and then secondly, within those resources, what resources have are beginning to address really the profound issues of stigma, which can oftentimes prevent women and families from seeking the care that they need. So I'm wondering if Prabha could answer that question as well.
Thank you. I think training is so important, and at all levels of the health system. So from policymakers to obstetricians, midwives, community health workers, peers education as well as the community itself. So I think it's so important to develop different programs for each group. And like I think we found in our landscape analysis and subsequent consultations, it have, the importance of co-design is really paramount, because it's so easy to develop a training program which and we know that one size does not fit all. So I think developing a framework and then adapting it to different contexts is extremely important. One of the things that we found useful in India is to involve, for example, if you're training obstetricians, to actually involve obstetricians in the training program. So have a combination of mental health professionals and obstetricians doing the training, so that there's a sense of ownership. Similarly, if you're going to train midwives, then ensuring that alongside mental health professionals, you have midwives who will also be a trainer, so that it's again very meaningful and context specific. So I think there are resources currently available in the form of webinars, slide sets. The Marseille Society for International, the International Marseille Society for Perinatal Mental Health has several resources available on their website, and are also going to be promoting many more programs. And I think we will definitely, as part of this community of practice, ensure that there are enough resources available for training, which can be freely used. There are some certificate courses also available, and that information will also be provided.
Thanks so much, Dr. Chandra. So at this point, we have to acknowledge that we have far more questions than we have time, and there are any number of very interesting questions that we'd love to respond to, but I think we have to acknowledge that, again, one of the functions, one of the purposes of this community of practice is to exchange knowledge and resources. It's clear that people really have very specific questions about specific populations. I think that that's one really critical aspect. There are a number of questions about specific tools for screening, how to overcome stigma and shame, and also just really how does one not only use tools that are appropriate for screening, but how does one as a provider gain the education and knowledge that is needed in order to respond adequately to this woman in front of you who is presenting with ill health. We keep saying over and over that there's no health without mental health. So really key point. So what we'd like to do is wrap up with this final question that talks about what are the special perinatal mental health needs of young adolescent mothers, or for the population that has experienced gender-based violence. And as we know, that's a significant portion of the population. So Iffy and Dr. Chandra.
So I'll probably address the issue of gender-based violence. We know that rates of violence in pregnancy are quite high, unlike what we think. And while there is some evidence to say that violence may come down in the second trimester, it goes up again in the third, and then in the postnatal period, there's again a big rise. We also know that the impact of violence is on pregnancy outcomes in terms of hemorrhage, abortions, preterm births is quite high. I think that, like I mentioned earlier, a linkage between perinatal mental health services or perinatal health services and gender-based violence services is so crucial. Many times in many countries, these services are working in silos, and it's important for us to engage with both services, and for them to be offered in a way that are safe and don't escalate violence. So it's a very fragile state of affairs, a very delicate balance that has to be considered when we are supporting women who are facing violence. So I think it's crucial to understand that you need to be able to offer services that are safe, that will not increase violence, and to be able to identify violence when it happens in the antenatal and the postnatal period. So I think these are some very important training areas that we should be addressing during the training of various groups of people. Also be able to provide resources to women which they can access using technology remotely. And these are some things that are sort of increasingly being used in various countries to ensure safety as well. About the adolescent pregnancies, I'm going to hand it over to Ify.
Thank you, Dr. Chandra. For the community of practice, we had mentioned in our presentation that one of the vulnerable groups that will be prioritized is the adolescent group, because they are often discriminated when they are receiving maternal care service. So for us, we are very deliberate about designing products that will be beneficial for them to ensure they receive respectful maternity care, regardless of their status, married or not. And what's important is that within the advocacy pack that we'll be looking at developing, we're going to ensure that there is no form of discrimination, and it's emphasized on the fact that every person, every woman who comes to the service, to the hospital to receive service, is respected, regardless of his or her status. And also to emphasize on the fact that we're going to be integrating some gender frameworks to ensure that there is a collaborative advocacy tool that focuses on the needs of adolescents during pregnancy and post-pregnancy, to ensure that they achieve the best mental status that they are, to be able to care for themselves and for their babies as well. Thank you.
Thanks so much, Ify. And again, we just want to acknowledge that there are so many more questions than we could possibly answer in this period of time. And but this, again, your active engagement, your questions are really helping us to flesh out where the interests lie and what the specific questions are. And we really wish that there was time to answer adequately some of the very thoughtful questions. But again, one of the objectives of this community of practice is to do precisely that. So, and I also, there's a comment just talking about how do we engage cultures, context, professionals who are not Anglophone. And again, that is something that we will have to take into serious consideration and begin to map what it is that we can do to help make certain that we're inclusive in terms of languages and different country contexts. So with that, what I'd like to do is turn it over to our colleague Anam Bhatti, who's going to advise you all of how precisely to sign up for the community of practice. And then once she concludes that, we will sign off and continue our conversation with you over the next few months and years, hopefully. So thanks, Anam, over to you.
Thank you, Suzanne. Next slide, please. Okay, so I am going to walk you through how you can engage and join the perinatal mental health community of practice. So our community of practice is on the IBP network. This is a large platform that has historically been used for family planning communities of practice, but has now also opened up to other communities of practice as well. And if you are already a member of this network, it will be very easy for you to join our page, but if you are not, that's okay. I will walk you through how to join the network itself, and then how you can find our page on the network. So in order to join the IBP network, you would go to this website, ibpnetwork.org/login. And there you would fill out a very short form which asks for your name, your email address, and where you're coming from, so which country you're coming from, and request an invitation. As soon as you request that invitation, your request will be accepted by the IBP network administrators. Once you've received your approval, you can find our page on the IBP Exchange and search. And in a moment, I will show you exactly how to do that. Next slide, please. Now, if you are already a member of the IBP network, you can actually either use this QR code right here using your phone, or you can type into your web browser this short web site, which is the IBP network website, but will take you directly to the PMH Community of Practice page. And once you do that, you are able to ask to become a member of the page itself. And since it is an open page, your membership will be automatically accepted. And that's about it. You'll be able to interact with the various discussion boards, the live forums, as well as with other community members on the page. And if you are interested in joining any of the technical working groups, we encourage that you leave us a comment on the page itself. As we continue to make our list and grow our technical working groups, we will make sure to reach out to you directly through the network to be able to start that engagement process. So if I can actually take control of the screen in a moment, I am going to share. Oh, that's strange. Hold on one second. Here we are. Okay. So I'm going to show you how to access the page on our network. So once you go to the IBP network page, you would click request to join if you are not already a member, and you can fill out this very short form, request your areas of interest, and submit the request. And once you've been approved, you'll receive an email based off of the email that you've sent to, or you've noted on the short approval form. You'll receive an email, and once you click that email link, you'll be able to log in. Once you've logged into your page, and oh no, let's see what's going on. My apologies. I'm not sure what's going on with the network right now. Okay. Anyhow, I will fix that in a moment and see what's going on. But once you log into the page, you should be able to go to the IBP Exchange. Let's see if this will work for me. Oh, it does. Wonderful. Great. So you should be able to go directly to the IBP Exchange. And if you do not see the group, if you're not a member of the group already, you can actually search the group here, or you can search the group using this magnifying glass as well, and just type in perinatal and you should be able to see your community of practice. Once you click the community of practice page, it will take you to our landing page where you will see who you can contact if you have any questions regarding the community of practice, And then here in the live feed, you can actually leave comments for the group members. And here is where we encourage you to leave comments of the technical working groups that you may be interested in joining. And then please stay tuned at this page if you are interested in any materials or any sort of small projects that we may be doing in the future. You'll also find discussion forum here that we will be populating. And then in addition to that, you will also be able to get any news and research updates here as well. So I will go ahead and stop sharing my screen. And if we can get the slides back up, please. Great. And these are just a few of the resources that you will be able to find on our page. So this will include our landscape analysis that Shannon had mentioned, as well as some of our peer-reviewed publications and other commentaries and our theory of change as well. So thank you, and over to you, Suzanne.
Thanks so much, Anam, for walking us through step by step how to do this. So if you could please, here you can see that this is the way to join using the QR code, and hopefully you can manage to walk through the process in the first try. If not, try again. And certainly we will be communicating with you after the webinar finishes, and you'll see both contact information and additional resources. But can you go to the next slide, please? So at this time, we'd like to go ahead and close the webinar. And I want to first both thank our panelists for being so responsive and both presenting the different aspects of creating the community of practice, and then being so responsive to the questions. I also want to acknowledge that our group of participants is varied, and there are many on here already with very deep expertise who could have answered any and all of these questions as well. So again, thank you for participating today. Thank you for your interest in the community of practice. Please do anticipate further communication from us. We will be sending out both the recording and the slides from today, so you will have those if you've registered. And then also, I really want to emphasize once again, we really want to emphasize that this is a community of practice that is evolving, and we really appreciate input, strategies, directions to continue to shape this so that it serves the needs of perinatal mental health providers and programs all over the world. So thank you so much, and we look forward to being in contact with you. So have a good evening, morning, rest of your day for those who are different parts of the world, and we will be in touch. Thank you.